Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Abdusalam Alrmali. I graduated from Tripoli University, Faculty of Dentistry, and I have a master's degree in oral and maxillofacial surgery and oral implantology and a fellowship in ICI. Today I'm going to talk about the current concept and challenges in soft and hard tissue augmentation, specifically regarding the sticky bone and the PRF. Before we talk about the topic, we have to start with the biology because this is the basic for soft and hard tissue augmentation. In the biology, days after wound healing, there are three stages: inflammation stage, cell proliferation stage, and matrix remodeling stage. In inflammation stage, the bleeding and coagulation will persist for 1 day. After that, cell proliferation, matrix deposition in the form of angiogenesis and fibroblast migration. The final stage, maturation of the wound, or formation of extracellular matrix synthesis. This is what happened after tooth extraction. After tooth extraction, the day 1, formation of the blood clot. After that, initial angiogenesis and formation of a new blood vessel and migration of the cells. Start formation of the bone and maturation, finally maturation of the bone in the form of lamellar bone after 6 months. So, let's see what's happened in the bone after tooth extraction without any intervention. This is a systematic review published in 2011 in the Clinical Oral Implants Research, demonstrating that the maximum bone loss, horizontal and vertical, will happen in the first 6 months, especially in the horizontal. Regarding the horizontal type, up to 60% in the horizontal and up to 20% in the vertical bone loss. And all of us familiar with this diaphragm, demonstrating that the horizontal and the vertical bone loss will start and continue even after 6 months, described by Zarab in 1985. So let's compare between if we not to treat the extracted site without any intervention and treat the extracted sites. Treatment of extracted sites regarding the bone material, collagen or PRF or anything inside the socket to maintain the dimension of the socket, or untreated sites, the socket will collapse and the resorption will be more rapid. Is there evidence regarding this? Yes, this is the effect of alveolar preservation or alveolar socket maintaining after tooth extraction. There is a systematic review and meta-analysis published in 2014 in High Impact Factor International Association of Dental Research, and illustrating and concluded that subgroup analysis revealed that the flap elevation, using of membrane and application of xenograft or allograft associated with superior outcome, particularly on the mid-buccal and mid-lingual height. So, the application of socket material preservation will improve and maintain mainly the mid-buccal and mid-lingual bone. And when we have a compromised socket, as in this photo, compromised socket when extracting the tooth, if you don't do any intervention or put anything inside the socket, the collapse will increase. The resorption will more dangerous and more worse. So that's why we prefer in these types of sockets, if you don't want to place an implant, immediate implant, better to preserve the socket and augment the socket with the graft material covered with membrane or BRF and primary closure. After more regarding the bundle theory, buccal bundle theory, because in the aesthetic zone, a special consideration because the buccal bed of bone is very thin, less than most of people, less than 1 millimeter, and the blood supply will compromise after tooth extraction. That's why we face this complication, static complication, when we place the implant in the static zone in the socket of the tooth or slightly palatal. The buccal bundle bone will resorb. Buccal plate of bone will resorb, and after that we facing a static failure. This is the CBCT study comparing the thickness of buccal. We can see from this CBCT photo that the thickness of buccal bed of bone is very thin, especially in the static zone. So another technique published in 2010 by the Mark demonstrating that preserving the buccal blade of bone and tissue will be achieved and proved if we maintain part of the root buccally. And he described this technique as socket shield or partial extraction therapy. So we can maintain the part of the root buccally, we can augment the remaining part with the bone graft and the BRF, and there's a special kit designed for this technique, or we can place the implant slightly away from the and below from this shield. And this is the CBCT showing implant placed slightly palatal. This is the basic rule actually in the immediate implantology in aesthetic zone. We always place the implant in slightly palatal, not in the same physiological axis of the tooth, slightly palatal, and keeping a jumping gap between the implant and the buccal bed of bone. And there is histological proof also, but this is an animal study, that the implant osseointegration will not be affected even with socket shield phenomena. And the stability of the buccal bed of bone and soft tissue will be more better. And we are waiting for more evidence and more compared studies. This is the implant placed slightly away from the socket part, from the shield part, and this is the distance we can fill it with bone graft or BRF. Today, the stem cell and regeneration and regenerative medicine is globally raised, and the emphasis to do a research based on the biology is rapidly growing. What we need if we want to achieve a regenerative medicine, what we need scaffolds, cells, and signals. All of this will work together to achieve a regeneration in the form of vascular and mechanical environment. So tissue regeneration actually by stimulation of growth factors and by application of biological rules. Some of these biological rules related to the patient regarding the general health, the oral hygiene, smoking, other factors, and some factors related to the vessel growth itself. What the function of these growth factors and where we are released. Growth factors released mainly from the platelet and leukocyte. More than 150 growth factors released and has major role in the cell proliferation, angiogenesis, and the wound healing. Slow release of cytokines are achieved regarding the PRF and BRGF and PRP. But the maximum release, slowly release, drop by drop, continuous slowly release can be achieved mainly in the PRF. So tissue stimulation with growth factors, regarding the history, the first generation called PRP, platelet-rich plasma, described by the Marcus in 1998. The year after, BRGF, platelet-rich growth factor. There are anticoagulants in both PRP and BRGF. The last, BRF, described by Shukroon 2001, and Shukroon advised to avoid anticoagulant. Why? We have to avoid anticoagulant because we need the natural clot to take it and to be used as a matrix. So, to get a clot, anticoagulant must be avoided. And this is described by Shukroon 2001. This is the concept, gold concept of the Shukroon, to maintain the blood clot rich with leukocyte and platelet. And this photo showing 3 layers after the tube finishing centrifugation. This is the serum layer, and this is the PRF layer, and this is the packed RPC down below. Where are the white blood cells in the PRF? Is it in the top or in the bottom or between the yellow and the red? There is a last research published by Shukroon et al. In 2016 optimized the platelet-rich fibrin with the low speed concept. Because now our target to low the speed and increase the time to give the chance for more growth factors to participate and release. And we can prove, and it's proved, that the WPC is present mainly at the bottom between the red and the yellow. That's why we have to avoid to cut. We have to peel off the blood clot from the packed RBC. Avoid to cut this junction because most of the WPC present on this junction between the red and the yellow. Keep in mind that the speed of withdrawing the blood is the major factor in the amount of the PRF. We're comparing this PRF with this PRF, the same from the same body, from the same blood, but this PRF is withdrawn at very rapid time, and this PRF take long time to withdraw the blood. That's why the coagulation start outside the body or outside the centrifugation. PRF properties. PRF is the tissue matrix, the main physiological scaffold for tissue engineering, because it acts as tissue matrix. And when you have a tissue matrix, you have a tissue, soft tissue. When you have a tissue matrix, you have a bone, because you have a base that the soft tissue will form above and the bone will form in. There is the second advantage of PRF is releasing of growth factors, slowly release of cytokines that might help in cell proliferation and wound healing. Evidence strongly support that the new characteristic PRF as a bioscaffold and reservoir of growth factors tissue engineering, 2010 Tissue Engineering Journal. And the evidence also can get it from this pyramid of the research. And the highly level evidence, systematic review and meta-analysis, clinical randomized clinical studies, not the case control, not the case series. So you have to filter, you have to use your mind to filter the literature and the evidence, take the systematic reviews and highly level clinical studies, comparative randomized clinical studies. Don't depend on your conclusion or your decision on the case report or animal studies or laboratory studies or expert opinion. This is the first use of PRF as a tissue matrix and soft preservation, used at the plugs After extraction, debridement, insert the plugs inside the socket, take suture, and this is the healing after 2 weeks. There is a proof regarding using of the PRF and the socket preservation to accelerate the soft tissue healing. This is approved. This is a systematic review, 2015, International Journal of Maxillofacial Surgery, that the use of plasma concentrate accelerate the healing of soft tissue epithelialization and reduce the post-operative pain and discomfort. Especially, we note this when treating the patient with dry socket with the PRF. Dramatic decrease of the pain and discomfort after using the PRF. But, however, there is no evidence today to confirm that the plasma concentrate improved the hard tissue regeneration. No evidence until today. So, using of the PRF after tooth extraction has the advantages of accelerated soft tissue healing and epithelialization. We know the gold technique for treating gingival recession is the connective tissue graft, doing a tunneling technique and insertion of the connective tissue graft that harvested from the palate. But is there a chance for PRF to augment the soft tissue and use as soft tissue graft for root coverage without soft tissue graft? Yes, because as I said, when you have a matrix, you have a connective tissue. Another case, doing a tunneling technique, insertion of the PRF, and sling suture, and this is the healing after 3 months. So this is the evidence about using of platelet-rich fibromembrane in the treatment of gingival recession. Another systematic review and meta-analysis 2016 that conclude there is no significant difference between using of PRF and the platelet-rich fibrin. However, the keratinized mucosa width gained significant higher in the group which augmented with connective tissue graft, just the thickness, but both can work. This is the weak evidence when comparing the two cases. When one case treated with collagen membrane, another case treated with PRF, and they conclude the PRF can be used and more efficient than the collagen membrane. This is the weak evidence because you're comparing just two cases, a report of two cases comparing with each other. You cannot take a conclusion from studies like this. We can use the PRF as adjunctive in the treatment of periodontal intraoral defects, and this is a randomized split mount. This is the very high ranked study, split mount in the same patient, and they conclude that the conjunctive use of PRF and combination of collagen membrane is more effective in the treatment of intraoral defects in the chronic periodontitis compared to collagen membrane alone, because adding of the PRF will improve and accelerate the soft tissue healing over the membrane. Even the injectable PRF can be used in these cases. Another use of PRF as a tissue matrix in sinus lifting without bone graft. Yes, you can use PRF in the sinus lifting without adding of the bone graft, but you have to place the implant to maintain the PRF and the membrane height. You can put more than one plug in the maxillary sinus, and you have to place the implant simultaneously. And this is the evidence. Use of the PRF as sole filling material during augmentation of sinus lifting. High volume natural regenerative bone will be kitted around the implant, and this is radiographical and histological studies after 6 months. Another studies with up to 6 years follow-up that proved that the formation of the bone around the implant with the PRF augmentation. Same studies. Even with the flapless technique, crystal approach, we can use the BRF using HPISE technique with autologous CGF or BRF. The same. Very common complication that may face you when using a lateral window approaching the maxillary sinus, trying to elevate the membrane. Membrane perforation is the most common complication that might be occur in the sinus lifting. So the BRF will help you a lot when you're facing such this complication. You can use the BRF more than one layer, double layer, and fix it with the tag on the lateral wall of the maxillary sinus. Place your implant, place more BRF, and cover the window outside with the BRF again. This is, as we said, after sinus perforation, can place BRF. Even with facial aesthetics, you can use BRF instead of using fillers, because this is the natural product from the patient implant, and there is no harm from using the facial aesthetics, and this case achieved by or done by Cleopatra. This is the before and after using of injectable BRF and the facial aesthetics. You can also mix the IBRF with the fat, and this is the study proved that the result suggests that the combination of fat and BRF is more effective than the combination of the fat and PRP in facial aesthetics. Regarding the platelet-rich plasma for the diabetic foot, there is a systematic review and meta-analysis suggests that there is significant evidence regarding the use of PRP for people with diabetic foot. And if we compare the blood supply with the right and the left on the normal patient healthy wound, this is in the healthy wound, and for diabetic wound, there is a big difference regarding blood supply, because all of us know that the problem in the diabetic patient is the blood vessel and vascularity and the thickening and the hypoglycemic and ketoacidosis. All of these factors will affect, and some of lack of some growth factors will affect the healing. So diabetic foot ulcers, the evidence 2014 that the many therapeutic modalities available, but the using of growth factors and the platelet-derived growth factors may help adjunctive care. Another study showed that the healing of PRP grew significantly faster than the without the PRP. And another study published in 2000 that concluded lack of insulin-like growth factor in the basal keratinocyte. And I think this is the point, because because the diabetic patient has the problem in the vascularity and in the healing, plus lack of insulin-like growth factor in the basal keratinocyte, that very, very important in the epithelial closure and skin closure. That's why the diabetic patient complaining always from persistent ulcer doesn't heal even after months. And the growth factors start to use in treatment of diabetic foot 2003, and topical derived growth factors showed significant benefit and considered when non-healing in other group. And this is the case study with the BRF. This is the before and after diabetic foot ulcer. And this is another case, my colleague working with me in the university, and I did the debridement for this patient, removing the necrotic tissue, placing the BRF, suture tied over the BRF and gold foil. This is another case. This is the same case, this is before and after. 2 months after, complete healing of the ulcer. And I have special experience because I'm working in the hospital. working with orthopedic surgeon. Orthopedic surgeon has a problem when facing a gunshot injuries and difficult transferring the flap in some areas of the body. So they consult me about to manage exposed plates, exposed bone in very small areas. I try to use the BRF for those patients, and this is one of my case, exposed plates, and this is before and after using the BRF. Another case of exposed K-wire and tendon using the BRF over suturing, injectable BRF. After that, this is 2 months after. 2 months after, you can see the formation of the new blood vessel around the covering all the tissue and around of the ulcer. And this is the skin graft. This is before and this is after. Another one, you can use injectable BRF with the skin graft. Another case, treat with BRF, you can evaluate the formation of a new blood vessel. BRF will resorb and formation of blood vessel in place. Another case, when they plan to do a bone graft, I just prepare the site for him, removing the necrotic bone. The orthopedic do this, removing the necrotic bone, replacement of the edge. I prepare the BRF for him, and they place the BRF inside. After that, doing a local flap with skin graft, and this is the healing. This is before and this is after. Another case, soft tissue injury with the gunshot. Rapid healing of soft tissue and skin can be achieved even after two weeks. Another indication of using the BRF, because as a maxillofacial surgeon, we're facing a difficult complication which is called osteonecrosis of the jaw. We can face this complication, especially with the patient taking bisphosphonate IV, and this complication can be treated recently with using of the BRF. And I have a special case. This is my case. Patient came to me complaining from non-healing sockets and bone necrosis around the first permanent molar. I extract the tooth surgically. I remove the necrotic bone and I place the BRF and do primary closure. This is maybe this photo after 3 days or 4 days. And I achieve complete healing after 2 months. Complete soft tissue healing after 2 months with using of the BRF alone. And I think this for the stage 1 and stage 2 and stage 3, even stage 3, there is a case, more than one case report. I noticed a recent line of treatment for the osteonecrosis, and we need a strong evidence, comparative study. But the problem for those patients, the limitation of the cases. Limitation of the cases will limit the clinical type of study. This is another study regarding 15 patients treated with the BRF. Healing achieved in 1870 was obtained success rate with the BRF alone. For the bone graft and sticky bone, we can use a bone graft with a sticky bone to make which is called a sticky bone. After we elevating the flap, we can use the sticky bone for ridge augmentation, covered with BRF and closure of the flap. In this case of mesh, the patient has horizontal and vertical bone loss. We can see this is the old bone. We adapt the mesh, and this is the new bone. This bone was xenograft mixed with autograft, and the BRF. Exudate. What's meaning for exudate? This is which is uh, the remnant of the BRF in the box after hydration. You can use this exudate to hydrate the graft, rinse the surgical site, and storage of autologous graft. It is better than keep the autologous graft in the saline or in the blood. It is better to keep it with exudate because this exudate is rich with fibronectin. This is the formation of the sticky bone. What's the big advantage of sticky bone? This is no granules mobility and faster vascularization, because within the bone you have a matrix, and this matrix will accelerate the formation of angiogenesis and vascularization. And this is the golden recipe for successful bone graft. Mainly autograft 75% mixed with allograft or xenograft. As I said, after we harvesting the bone block, we can place in this exudate to correct the vertical and the horizontal bone loss with apical matrix suture, and commonly displace the flap to cover and watertight the flap. And this is the healing after 2 weeks. Another case of ridge splitting. After placing the 2 implant, we can use also the sticky bone, cover it with PRF with apical matrix suture. This is called apical matrix suture, to keep the tension away from the edge. The question now, does the platelet fibrin enhance the bone quality and bone quantity for alveolar cleft patient? Actually, we did running a study in the alveolar cleft patient about using of the PRF mixed with a bone to form a sticky bone, using the PRF to cover the nasal layer, because we know that the key for success of alveolar cleft graft is the watertight nasal layer closure. So we did regular watertight closure of the nasal layer, covered with PRF. After that, we're placing the bone to fill this cavity, covered with a collagen membrane, covered with PRF and closure. We're running this study, but we didn't publish it yet. So what's about the efficacy of platelet plasma of fibrin osteoarthritis? There is a systematic review and meta-analysis 2015 on the basis of the current evidence that the PRP injection reduced the pain more effectively than placebo injection in the osteoarthritis of the knee. And another paper, position paper with American Academy of Orofacial Pain, that they conclude using of the PRF in the temporomandibular joint reducing the pain significant, especially in osteoarthritic patient. So now in my clinic regular, I am using the PRF for osteoarthritic patient to inject it in the intra-articular. Also, I'm using the PRF for the patient with hypermobility and recurrent dislocation as a pleural. And this is the proof that the injectable PRF, I think now there is opportunities in the regenerative dentistry. All of us, we know that the injectable PRF will bring and will add a lot of something new in the dentistry field. All of us familiar with the RET, regenerative endodontic treatment, or regenerative endodontic therapy, regarding the treatment of open apex of immature root. What about the using of the platelet concentrate for revitalization of immature necrotic teeth? Despite the potential effectiveness, but they proved that promoting growth development of necrotic immature teeth with the platelet concentrate. Also, we can use another case of using the sticky bone with PRF in case of immediate replacement implant and with red splitting. In case of immediate replacement implant, we can fill the jumping gap in the case of red splitting or immediate implant with the sticky bone and cover it with PRF. But as we said in the beginning of the presentation, the problem was in the buccal plate of bone is very thin in the static zone. So the resorption will happen if you place bone graft or PRF. So better to go to socket shield technique than extracting the tooth and placing a bone graft. Another modification in the PRF called PRF pancho in case of second stage healing or when using overdenture like this case, using the placing the over PRF pancho over the implant and closing primary closure. This is the healing after 4 days. After red splitting, as I said, we can place a sticky bone, and this is the healing after 2 weeks. Amazing soft tissue healing, very thick, improving the thickness, improving the contour of soft tissue. And this is the case in the second stage after using the PRF to augment sticky bone PRF to augment the labial bone. I don't know this contour, this excellent contour will be maintained after a long time or not, because this is the case, not a case of socket shield. This is natural case, extracting the tooth, augmenting the socket after that, placing the implant, and this is the photo in the second stage. So, which scientific evolution in the platelet concentrate? The PRP, still PRGF, no big change. I think the PRF has the scientific evolution, and regarding the LPRF and the APRF and the IPRF, we know that the significant improvement and the change from 2001 to 2017. And we Shukroon call this smart blood concentrate because all of us now will get this type of phone. All of us have a special smart phone. That's why we have to also have a special smart blood concentrate. Shukroon 2013 described the advanced PRF, reducing the G-force, reducing the more concentration of growth factors and leukocyte. The year after, producing the IPRF, which is may contain some of the stem cells. The IPRF doesn't differ from the APRF. The same tube, you can use the same tube, but with different speed and different time. The advantages in the IPRF, there are high concentration of leukocyte, more than the PRP, high concentration of fibrinogen, high concentration of plasma protein, and after 15 minutes, spontaneous clotting of the IPRF can occur. If we're comparing the eye with the PRP with PRGF, the leukocyte is very high in the IPRF. There is no significant difference regarding the platelet between the three, but there is significant difference regarding the leukocyte. We can use also, in my clinic, I am using regularly the PRF with collagen cone hydrated with PRF exudate after cyst inoculation. I know it is a contained cavity. The healing is occurred with PRF or without PRF, with bone graft or without bone graft. But we want to accelerate the healing. We want to support the soft tissue overlying this cavity. So that's why I am using the PRF with bone graft, sometimes with collagen cone in other cases. And this is the healing of the same lady after 2 weeks. Soft tissue healing. Excellent. Soft tissue contour. Excellent. Soft tissue healing after 2 weeks. After 4 months, also, this is the healing of the bone. Complete consolidation of the cavity after 4 months with using of the bone graft and PRF. Another case, after removing the cyst, this is the healing after 2 weeks. This is the collagen cone inside the cavity covered with PRF. Another case, after removing the inculating the cyst, we're placing the bone graft covered with PRF, and this is the healing after 3 weeks, I think. As I said, significant and dramatic improvement in the pain and discomfort regarding the dry socket when using the PRF. And this is one patient came to me with dry socket in the upper premolar. I give small injection of local anesthesia, and I'm cleaning the socket, placing 2 plugs of PRF, and doing horizontal matrix suture. And this photo after 3 days. And the patient reported significant decrease of the pain and discomfort when using the PRF and treating of dry socket. Another advantage of PRF when using a mesh. You can cover this mesh because all of us familiar that the main complication of using the mesh when we want to augment the edge is the exposure. So when using the PRF over the mesh, even the exposure is happen, the PRF will expose, not the mesh. Another case after inoculating of the cyst, placing the PRF in case of vestibuloplasty, and this is the healing. In case of multiple frenum, as this case, doing frenotomy rather than leaving the place exposed, I place the PRF. This is the color of the PRF, and this photo, I take this photo after 3 days. Another case of very atrophic ridge, and there is a concavity in the place of the upper lateral and the central. Very narrow ridge in the place of the central and the lateral concavity. In this case, we cannot place the implant. The best for this case to do a block graft. That's why I harvested a block graft on the chin, mixed it with xenograft, doing a block graft on one side, tenting technique on other side, placing of sticky bone covered with PRF and collagen membrane and closure. This is after healing after 4 months. I'm placing 2 implants on the grafted side. But the question now, does the PRF is enough to get constant results for the soft tissue and for the bone? Because generally we'll talk about the soft tissue healing and the bone healing, what the advantages of using a gold technique or using the PRF. We talk about that there are factors related to the patient and another factors related to the growth of blood vessel. So I think the answer is no. PRF alone is not enough to get constant results. Finally, I want to give you a home message that a reducible protocol for the PRF must be followed to get constant results regarding the quantity and the quality. After that, the principle of using safe protocol and select the patient, improving the patient factors and the soft tissue factors and the growth factors This will aid to get a constant, reproducible results and stable gingiva. There's a long way to go. If we want to get long terms of tissue stability, we can expect very nice improvement, I think, with the ABRF and IBRF. Finally, this is the final slide, and I want from you to keep calm and go better. And thank you very much for your attention. أحب أشكركم وأشكر الدكتور مازن أن دعاني حقيقة لحضور والمشاركة في هذا المنتدى Dentistry Online. And this is my email and this is my Facebook لو حد عنده أي استفسار أو أي سؤال. وأنا متأسف إني ما كنتش أونلاين لأن موضوع النت ممكن يكون بطيء، يعني مش مساعدني. وأنا طبعا من ليبيا والمحاضرة سجلتها في مصر، وبعد يومين راجع لليبيا، وأتمنى لكم التوفيق إن شاء الله. والسلام عليكم ورحمة الله.